Imagine a medical emergency. Something so swift it can just turn a perfectly healthy day into a real crisis in hours.
Yeah.
Something that could be, tricky to spot early on, but needs immediate action.
Absolutely.
Today, we're doing one of our deep dives into exactly that kind of condition. We're pulling directly from this stack of really detailed revision notes a listener shared. They want to get a proper handle on this, and frankly, it's crucial stuff.
That's right. And our job here with these notes is to kind of cut through all the detail, convert them into a really clear, high-yield exploration focused just on bacterial meningitis.
Yeah.
Think of it like turning that big study guide into the absolute need-to-know essentials, the stuff you really need to understand and remember.
And that's the challenge, isn't it?
Yeah.
Because these notes, they're packed, absolutely packed with info. So we're here to sort of guide you through them, pull out the critical facts, explain why they matter, and we'll hopefully make them stick. Whether you're revising for an exam or honestly just want to be properly informed about a really serious health risk.
Exactly. And we'll follow the structure that's laid out in the notes themselves. Start with the basic definition, then move into what causes it, the etiology.
Right.
Then who's most at risk, how it actually impacts the body, what other conditions might look similar.
The differentials. Yeah.
Differentials, exactly. How common it is, epidemiology, what symptoms to look out for, how it's diagnosed, investigations, the vital steps in management, the prognosis, so the likely outcome, and finally, the complications.
So, yeah, consider us your navigators through this dense material. Let's start right at the top, getting a clear picture. What is bacterial meningitis, according to these notes?
Okay, so at its heart, bacterial meningitis is described as a severe infection.
Severe.
Yeah. Specifically, it involves inflammation of the meninges.
And the meninges are?
Those are the protective layers, kind of like membranes, that wrap around your brain and your spinal cord.
Okay. And it's caused by bacteria getting in somewhere.
Precisely. It's caused by bacteria managing to invade the space where the cerebrospinal fluid flows the CSF. CSF, right. That clear liquid that cushions everything.
That's the one. Cushions and protects the brain and spine.
And the notes, they really hammer home the urgency here. They call it a medical emergency. Needs prompt diagnosis, prompt treatment.
Absolutely. And there's a very good reason for that. If it's untreated, or even if treatment is delayed, it can escalate incredibly quickly.
Leading to
serious, potentially life-altering complications, or even, well, death.
Huh.
The notes point to a few main bacterial culprits that cause most cases. Streptococcus pneumonia,
Okay.
Neisseria meningitidis,
Right.
and Haemophilus influenza type B, often called Hib.
Hib. Yeah. Heard of that one. And there's a specific UK point, too. Notifiable disease.
Yes, exactly. It's a notifiable disease here in the UK. And that status alone tells you the level of public health concern.
So takeaway number one, really. Severe bacterial infection. Brain-spine lining. It's an emergency, potentially deadly. You need to know that.
That's the foundation. Know what it is, why it demands attention. Got it. Severe infection, lining, bacteria emergency. Okay. Now, how do these bacteria actually get there? Let's move to the why, the etiology, the causes.
Right. So fundamentally, it boils down to bacteria invading the central nervous system. And those common ones we just mentioned.
Strep pneumo, Neisseria meningitis, KIB.
Yep. Those are the usual suspects the notes highlight again.
Do they normally start right there in the brain or spine area?
Usually not, no. Often they spread from an infection site somewhere else in the body. Maybe an ear infection or respiratory illness, something like that. Then they travel to the meninges, usually through the bloodstream.
Ah, okay. The notes also list some other bacteria, but say they're more common in specific groups.
That's right. Group B, Streptococcus, Listeria monocytogenes, and E. coli.
E. coli can cause meningitis.
It can, yeah. These ones often affect newborns or people with weakened immune systems. And importantly, the notes add that sometimes bacteria can get in directly, like maybe after a medical procedure near the brain or spine, or if there's been significant head trauma that actually breaches those protective layers. Lets bacteria straight into the CSF.
And just so we're clear, these notes are really focused just on the bacterial kind, right? Even though viruses and fungi can cause meningitis too.
Exactly. For this deep dive, we are sticking strictly to the bacterial causes outlined in these notes.
Okay. Now, here's where it gets really interesting and probably super important for anyone revising. The notes break down the likely bacteria based on the patient's age.
Yeah, this is really high-yield stuff. Think of it like different bacteria having different preferences, different hosts or routes they favor.
Okay, so for newborns, neonates.
For newborns, the notes flag Group B Streptococcus, Listeria monocytogenes, and E. coli as the main worries, often related to the birth process itself or maternal infection.
Right. Then moving up a bit, infants and young children.
The focus shifts. It becomes Haemophilus influenza type B Haeb, Neisseria meningitidis, and Streptococcus pneumonia. Although, thankfully, vaccinations have made a huge difference for Heb especially.
That's good news. And for adults and older kids.
Still see a lot of Streptococcus pneumonia and Neisseria meningitis, him too, but also potentially a wider range of other bacteria depending on the person's health and circumstances.
And the notes call out the elderly and anyone immunocompromised specifically.
Yes, they're more susceptible again to strep pneumonia, Listeria monocytogenes, but also some less common things like tuberculosis causing meningitis or certain gram-negative organisms.
And then there's hospital-acquired or post-trauma cases.
Right. If the infection develops in hospital or after a trauma, the notes list things like Klebsiella pneumonia, E. coli again, Pseudomonas aeruginosa, and Staph aureus. Often bugs that are more common in healthcare settings or found on the skin.
The notes even mention geography for meningococcal meningitis.
They do, highlighting that it's endemic, meaning it's kind of always present in parts of Africa and India. And it can cause big outbreaks, epidemics, particularly in sub-Saharan Africa, the meningitis belt, and among large gatherings like religious pilgrimages to Saudi Arabia.
Wow. So the big takeaway on causes.
Yeah.
It's specific bacteria. And knowing the patient's age, immune status, or situation gives you really crucial clues about which one is most likely.
Precisely. And that helps guide treatment choices really quickly.
Okay, so we've got the what and the why. Now, who is most vulnerable? Let's dive into the risk factors. The notes give us quite a list here.
Yeah, they start with the really prominent ones. Young age is a big one, especially infants and young children. Their immune systems are still maturing.
Makes sense.
And anyone with a compromised immune system, maybe due to conditions like HIV/AIDS or because they're taking immunosuppressive medication.
Yeah, in close contact is listed, obviously.
Yes, definitely. Living in the same house or being in crowded settings. That's why you sometimes see outbreaks in places like college dorms or military barracks. Having a recent respiratory infection or an ear infection, that can also potentially open the door for bacteria. And the notes mention certain medical devices, like cochlear implants, as a potential risk factor, too.
Travel comes up again.
Yep, travel to those regions where meningococcal meningitis is more common. And for the tiniest babies, newborns, factors around the birth itself can increase risk being born premature if the mother had an infection or if the membranes rupture early and stayed ruptured for a long time.
The notes had quite a few more factors, though.
They do. Smoking is listed, which can weaken respiratory defenses. Patients who have CSF shunts.
Those tubes to drain fluid.
Yeah, those. Or dural defects, basically holes or weaknesses in that protective brain covering. They create a direct potential entry point.
Spinal procedures are mentioned too.
Yes. Things like lumbar punctures or spinal anesthesia are highlighted as carrying a small increased risk, with Pseudomonas species specifically noted in that context sometimes.
And then there's a whole list of other medical conditions.
Yeah, a real range of chronic conditions that can increase vulnerability. Think of things that generally weaken the body's defenses or create opportunities for infection. The notes list bacterial endocarditis, diabetes, alcoholism, cirrhosis, drug abuse, kidney or adrenal problems, cancer, even things like hypoparathyroidism, thalassemia major, cystic fibrosis.
Wow, that's extensive. Seems like general health is a big factor.
It really is. And there are specific conditions highlighted too, like having had your spleen removed, a splenectomy, or having sickle cell disease.
Why those specifically?
Because the spleen is really important for fighting off certain types of bacteria, particularly the ones with capsules, which are common meningitis culprits. So without a spleen or with sickle cell affecting spleen function, you're much more vulnerable to those specific bugs.
Gotcha. And finally, the notes circle back to crowding again.
Yeah, just reinforcing why groups like military recruits, college students living in dorms are at higher risk for certain types, particularly meningococcal outbreaks.
So the key message for risk factors: highest risk at the extremes of age, in people with weakened immune systems, and in situations involving close contact or a breach in the body's defenses. Knowing these helps spot who needs that higher index of suspicion.
Exactly right. Helps prioritize who you're most worried about.
Okay, so we know what it is, who gets it, and why. Now let's get into the how. How does the bacteria actually make someone sick? By pathophysiology, the disease mechanics.
Right. So the notes describe the first critical step. The bacteria have to somehow get past the body's initial defenses. They need to enter the bloodstream usually, or in some cases, they might invade the meninges directly, maybe from a nearby infection like sinusitis.
And once they're in that meningeal space, our body fights back.
Right.
But that causes problems.
Exactly. The presence of these bacteria triggers a massive inflammatory response right there in the meninges. This is the immune system doing its job, kicking into high gear, but it's actually this inflammation that causes a lot of the damage in meningitis. Well, this inflammation makes the blood vessels in the brain more permeable, kind of leaky.
Okay.
And it pulls in loads of immune cells to the area to fight the bacteria.
And this big inflammatory reaction,
Yeah.
it harms the brain tissue itself.
It does. The inflammation plus toxins released by some bacteria starts to disrupt the delicate tissues of the meninges and the brain underneath. And critically, this process damages the blood-brain barrier.
That protective gatekeeper.
Exactly. It's normally super selective about what gets from the blood into the brain environment. When it gets damaged, things get chaotic.
And what does all that damage and leakiness lead to?
It leads to cerebral edema, swelling of the brain tissue.
Which is bad because the skull can't extend.
Precisely. So that swelling trapped inside the rooted skull causes increased intracranial pressure, or ICP. Big problem. It also messes up the normal flow and circulation of that cerebrospinal fluid we talked about earlier.
And the notes mention the specifics can vary a bit.
Yeah, depending on the exact bacteria involved and how the individual's immune system responds. But the core issue is this damaging inflammatory cascade combined with bacterial toxins. Understanding this helps make sense of why people get the symptoms they do.
Like the headache, neck stiffness, confusion.
Exactly. It's all linked back to this inflammation, the swelling, and the increased pressure inside the skull.
Right. So, takeaway for pathophysiology. Bacteria get in, trigger massive inflammation around the brain. This damages the protective barrier, causes swelling and pressure, and that inflammation and pressure drive many of the symptoms we see.
That's the crucial sequence, yeah.
Okay, let's switch hats now. Put on the clinician's hat. Someone comes in, maybe with a fever, bad headache, stiff neck. How do doctors figure out if it is bacterial meningitis and not something else that looks similar? This is the differential diagnosis part.
Right. And the first big point the notes make is that symptoms suggestive of meningitis are actually more often caused by viruses than bacteria.
Viral meningitis is more common?
Much more common, yes. And usually less severe, thankfully. But you can't assume.
But there's that classic triad or maybe quartet of symptoms that really screams worry about bacterial. The notes list them again. High fever, severe headache, neck stiffness.
And changes in mental status, confusion, drowsiness, that sort of thing.
And if you see that combination,
That's why the notes are so emphatic about the urgency. If bacterial meningitis is suspected based on those signs, you absolutely have to start antibiotics immediately, like right then, even before all the tests are back confirming it.
time is brain, as they say.
Am is brain, absolutely.
So what else could it be? What's on that differential list?
Well, besides other types of meningitis, like viral or fungal, the notes mention other serious infections in or around the brain. Things like a cerebral abscess, a collection of pus,
Okay.
or encephalitis, which is inflammation of the brain tissue itself, often viral. Even non-infectious things can sometimes mimic it, like a subarachnoid hemorrhage bleeding around the brain.
Wow. Even drug reactions or autoimmune disorders.
Yep. They're mentioned as possibilities, too, which just shows how tricky diagnosis can be, sometimes based on symptoms alone. The notes emphasize that sorting it all out relies on a combination of careful clinical evaluation, lab tests, especially analyzing that cerebrospinal fluid.
The LP fluid.
Right, the CSF from the lumbar puncture. And sometimes imaging, like a CT or MRI scan.
The additional notes mention the differential needs to cover other severe infections too, and anything causing altered mental state or maybe a specific type of rash.
Yes. And there's a key point in the notes about rashes. While that non-blanching purplish rash is a classic red flag for meningococcal disease.
The one that doesn't fade when you press a glass on it.
That's the one. Petechial or purpuric rashes can actually sometimes be caused by less alarming things, like just straining hard from coughing or vomiting. So a rash is definitely a worry sign, prompts urgent assessment, but it needs careful interpretation and context.
Right. So, takeaway for differential diagnosis. Lots of things can look like meningitis. But that core cluster of symptoms, fever, headache, neck stiffness, altered mental state, demands urgent investigation and, critically, starting treatment for the worst-case scenario, the bacterial kind, until you can prove otherwise.
Precisely. You have to assume the worst and act fast. Don't wait.
Okay, let's zoom out again. Look at the bigger picture. How common is bacterial meningitis? Who does it tend to affect most? This is the epidemiology section, focusing on the UK data in the notes.
Okay. So the notes estimate the UK incidence is somewhere around 2 to 6 cases per 100,000 people each year. But they do point out this number isn't static. It varies quite a bit by region and also by population group.
And confirming what we saw earlier, the group most affected is still infants and young children, right?
Yes, absolutely. Primarily due to Neisseria meningitis and Streptococcus pneumonia in that age group. And the notes mention again that big public health success story. Widespread vaccination against Haemophilus influenza type B, Haeb, has dramatically slashed cases caused by that specific bug.
That's great. The notes give a bit more global context, too.
Yeah, they mentioned that globally in developed countries, the incidence is generally a bit lower, maybe more like 1 to 2 cases per 100,000 per year.
And specific UK numbers.
They cite a figure of 755 confirmed cases in England back in 2017-2018, but also note that these figures and the specific bacteria involved can shift over time, partly because of evolving vaccination programs.
Right.
The crucial distinction the notes really hammer home here again is that while viral meningitis is relatively common, it's the bacterial form that carries that significant risk of death or severe, long-lasting complications.
They also give a specific rate for neonatal cases.
Yes, for culture-proven cases in newborns in developed countries, it's estimated around 0.3 per 1,000 live births. So not hugely common, but devastating when it happens.
So the takeaway for epidemiology. Bacterial meningitis isn't super common overall, especially compared to the viral types. But it's common enough, particularly in those vulnerable groups like young kids, to be a major public health concern, which really underlines why those vaccination programs are so vital.
Absolutely. Prevention is key.
Okay, so if someone does unfortunately get bacterial meningitis, what does that actually look like? How would they present? Let's cover the clinical features, the signs and symptoms.
Right. The notes describe the onset as often being pretty sudden.
Yeah.
You're looking for that combination of key symptoms we mentioned. A high fever, a severe headache. People often describe it as the worst headache of their life.
Right.
Neck stiffness, where it's physically difficult or painful to bend the neck forward, chin to chest. And crucially, altered mental status. Anything from confusion, irritability, to significant drowsiness or difficulty waking up.
What other signs might pop up?
Photophobia is common sensitivity to bright light. Seizures can occur. Vomiting is frequent. Irritability is mentioned as a particularly key sign in children who might not be able to describe a headache well. And potentially a rash, especially, as we said, with Neisseria meningitis.
And you mentioned infants might present differently. That seems important.
Hugely important. They absolutely can present differently. Instead of complaining about a headache or stiff neck, they might just have a fever, be feeding poorly, seem unusually lethargic or floppy or excessively sleepy. And a really key sign in young babies is a bulging fontanelle.
The soft spot on their head.
Yeah, the soft spot might feel tense or raised because of that increased pressure inside the skull.
The notes really stress again. Prompt recognition and getting medical help are critical.
Yes, absolutely critical. Because, as we've discussed, diagnosis often has to start based just on that clinical suspicion while you're waiting for test results. When a doctor examines someone, they might find other signs like seizures, maybe problems with specific cranial nerves affecting eye movements or facial muscles or other neurological deficits.
What about those classic neck stiffness tests, Brudzinski's and Koenig signs? The notes mention them.
They do. These are specific maneuvers to check for meningeal irritation. They can be helpful if positive, but the notes caution they aren't always present, especially early in the illness or in very young infants. You can't rely on them being negative to rule it out.
Okay. And ultimately, confirmation comes from?
Comes from analyzing that cerebrospinal fluid, the CSF, obtained via a lumbar puncture. That's what the notes reiterate.
Now, here's where it gets really interesting again.
Yeah.
The additional notes on presentation add some important subtleties, especially about those early, maybe less obvious signs.
Yes, they point out again that invasive meningococcal disease can present with that classic non-blanching rash, but they stress that actually a whole range of different features should make you consider it. And crucially, they highlight that overall, meningitis symptoms, especially right at the start, can be really nonspecific, just vague.
Making it hard to diagnose.
Exactly, especially in primary care or for parents trying to judge at home, it can be really challenging early on.
So what early, perhaps subtle features do the notes say we should particularly watch out for?
They specifically list leg pain, severe leg pain, cold extremities, so hands and feet feeling unusually cold, and changes in skin color, maybe looking pale or mottled. These are flagged as potentially important early warning signs that might appear before that classic triad of fever, headache, and neck stiffness really sets in, especially important clues in children.
Wow. Okay. So, takeaway for clinical features. Know the classic signs: fever, headache, neck stiffness, altered mental state, but be super aware that symptoms can be vague, especially early on or in infants. Look for those other potential red flags too, like severe leg pain or cold hands and feet, because recognizing it quickly is absolutely vital for a better outcome.
Agreed. It's often the whole picture, the combination of symptoms, the risk factors, how quickly things are changing, that raises that suspicion.
So you suspect it. Based on the symptoms, the risk factors, the whole picture.
Yeah.
How do doctors confirm it? How do they figure out definitively what's going on and identify the specific bug causing the trouble? Let's look at the investigations.
Right. So the notes explain the diagnostic process involves pulling together the clinical evaluation, lab tests, and sometimes imaging.
And the absolute cornerstone test, the most important one for diagnosis, is the lumbar puncture, the LP.
That's the one. It involves carefully inserting a needle into the lower back, into the space around the spinal cord to collect a sample of that cerebrospinal fluid, the CSF.
And what are they looking for in that CSF sample? It sounds crucial.
It really is. The notes list the key analyses,
Hmm.
the cell count, especially looking at the number and type of white blood cells,
Okay.
the protein level, the glucose level, how much sugar is in the fluid, a gram stain, which involves looking at the fluid under a microscope right away to see if bacteria are visible.
You can see them directly.
Sometimes, yeah. And a culture where they try to grow any bacteria present in the lab, which also helps identify the exact type and what antibiotics will work best. And sometimes more specific molecular tests like PCR can be done too.
Blood tests are also part of the usual workup.
Yes, definitely. Blood tests help assess the overall level of inflammation in the body, check organ function, and sometimes you can identify the bacteria from blood cultures too, especially if the person also has septicemia, meaning the bacteria have spread into the bloodstream.
And imaging, CT or MRI scans, when do they come in?
They're typically used less for diagnosing the meningitis itself and more for looking for potential complications, like significant brain swelling, cerebral edema, or maybe to rule out other problems like a brain abscess before doing the lumbar puncture, especially if there are signs suggesting very high pressure inside the head.
Ah, okay. And there's a really important practical point in the notes about the timing of that LP, the lumbar puncture.
Yes, this is critical. They state the LP should ideally be performed promptly when meningitis is suspected. However, it should be avoided or at least delayed if there are clear clinical signs of very high intracranial pressure, things like coma, specific neurological signs, or papilledema seen when looking in the eyes. Doing an LP in that situation carries a small risk.
But didn't we say treatment needs to start immediately?
Exactly. And the notes immediately follow up by stressing that starting antibiotics should never be delayed by waiting for an LP or waiting for imaging if bacterial meningitis is strongly suspected.
So treat first, ask questions later. Almost.
Pretty much. Treat empirically based on suspicion. If it's safe to do the LP, do it promptly to confirm and guide therapy. If you need imaging first, get it quickly, but don't delay those initial antibiotics.
Okay. So the CSF analysis is really the gold standard for confirmation and figuring out the type.
It absolutely is. The specific pattern of findings in the CSF provides crucial clues that help distinguish between bacterial, viral, fungal, or other types of meningitis, and identifying the specific bacteria, if possible, is essential for tailoring the antibiotic treatment effectively.
The notes give a bit more detail on what's checked in the CSF.
Yeah, they reiterate looking closely at the white blood cell count and type, the protein level, and the glucose level, plus doing the gram stain and culture. They also mention that if the initial results are maybe unclear, or if a specific unusual cause is suspected, additional tests might be run on the CSF sample.
And for kids presenting with that worrying fever and petechial rash combination,
The notes indicate that in secondary care, so in hospital, they'll likely run a wider range of investigations alongside the LP and blood cultures. Things like checking kidney function, blood clotting ability, the coagulation profile, maybe a chest x-ray if there's respiratory involvement, and sometimes cultures from other sites like urine or stool, serum tests for specific bacterial antigens, or maybe for syphilis in certain contexts might also be considered.
Now, what's fascinating here is the notes include a table, a summary of the typical cerebrospinal fluid characteristics for different causes: bacterial, TB, fungal, and viral. This looks incredibly useful for differentiating them, like classic exam stuff.
It absolutely is. This is the key diagnostic differentiator, seeing these patterns. Let's quickly run through what the notes highlight. For bacterial meningitis, typically you see high CSF pressure when doing the LP, a very high white blood cell count, and importantly, these are mostly neutrophils, the bacteria-fighting white cells. Protein level is high. And critically, the glucose level in the CSF is low compared to the blood glucose level. Why? Because the bacteria are basically eating the sugar.
Okay. Low glucose equals bacteria. What about TB meningitis?
Tuberculosis meningitis, often high CSF pressure again. White cell count is high, but the type can vary. Often neutrophils dominate early on, but it shifts towards lymphocytes later. Protein is high, and glucose is also typically low, similar to bacterial. Needs special tests to confirm TB.
Fungal?
Fungal meningitis, also often high CSF pressure. White cell count is high, but predominantly lymphocytes here, like later TB. Protein is high, and glucose is generally low. Again, needs specific fungal tests.
And the big contrast, viral.
Viral meningitis. This is usually different. CSF pressure might be normal or maybe high. White cell count is high, but usually predominantly lymphocytes. Protein level is often low or maybe slightly elevated. And the key differentiator, the glucose level is typically normal. Viruses don't consume the glucose in the same way bacteria do.
That table is brilliant. Seeing those patterns side by side, especially the cell type and the glucose level, really helps clarify how CSF analysis points towards the likely cause. So takeaway for investigations. Lumbar puncture and CSF analysis are absolutely key. You're looking for those specific patterns. High neutrophils and low glucose strongly suggest bacterial. But remember, prompt treatment often has to start before you even get these results back.
Exactly right. Clinical suspicion drives the immediate action. The LP confirms, refines, and guides the ongoing therapy.
Okay, so you suspect it or you've confirmed it with the LP. What happens next? Management. Time is absolutely of the essence here.
Totally critical. The notes are crystal clear. Immediate hospitalization and starting intravenous IV antibiotics are non-negotiable. It is a true medical emergency.
And you start those antibiotics based on your best guess initially, right? Before the lab results.
Yes, exactly. That's called empirical therapy. You choose broad-spectrum antibiotics right away based on what bacteria are most likely given the patient's age, their risk factors, and even local antibiotic resistance patterns. You're guided by national or local guidelines. You absolutely do not wait for the culture results, which can take 24, 48 hours or sometimes longer.
Makes sense. What else is involved in management besides the antibiotics?
Supportive care is hugely important. Things like ensuring the patient stays hydrated, usually with IV fluids, managing high fever, controlling pain, often severe headache pain, and treating any seizures if they happen. The notes emphasize continuous monitoring vital signs like heart rate, blood pressure, oxygen levels, plus neurological status, looking for any changes and checking how the patient is responding to treatment.
And sometimes more intensive support is needed.
Yes, severe cases often require admission to an intensive care unit, or ICU. They might need help with breathing, using a ventilator, especially if their consciousness level is low or if there's significant brain swelling.
The notes also mention non-prescribing management strategies.
Right. Close monitoring for signs of that raised intracranial pressure, the ICP, is vital. If it gets dangerously high, medications like mannitol might be given intravenously to try and draw fluid out of the brain and reduce the swelling. In the most critical situations, sedation and putting the patient on a ventilator can also help manage brain pressure and ensure good oxygenation.
And the public health angle comes up again here.
Yes, because bacterial meningitis is a notifiable disease in the UK. Any suspected or confirmed case has to be reported to the public health authorities.
Why is that so important?
It triggers a public health response. They work to identify people who have been in close contact with the infected person, like family members, maybe housemates, sometimes nursery or school contacts. These close contacts are often offered prophylactic antibiotics, just in case they're carrying the bacteria, to prevent them getting ill and stop further spread. Vaccination might also be offered if relevant, depending on the type of bacteria. And of course, routine childhood immunization programs targeting common meningitis bugs are a cornerstone of prevention.
What's fascinating here is the notes get really specific about antibiotic choices once you know which bacteria is causing the infection. This is where that empirical therapy gets fine-tuned.
Exactly. This is the targeted approach once the lab gives you the culprit. So for instance, if it's confirmed meningococcal meningitis, Neisseria meningitis, the notes list intravenous benzylpenicillin or ceftriaxone as typical choices.
Okay. What about strep pneumomeningitis?
For Streptococcus pneumoniae meningitis, the notes mention that giving dexamethasone, which is a steroid, alongside the antibiotics has been shown to improve survival and reduce hearing loss. The antibiotic choice itself will depend on microbiological testing for sensitivities, but high-dose ceftriaxone or cefotaxime are common starting points.
And Haemophilus influenzae type B.
For Haemophilus influenzae type B meningitis, intravenous ceftriaxone is listed for children, and cefotaxime or ceftriaxone for adults. Again, sensitivities matter.
What about those specific ones in babies? Group B strep or Listeria?
Right. For Group B Streptococcus meningitis in babies, typical choices mentioned are intravenous cefotaxime, maybe with amoxicillin or ampicillin. For Listeria meningitis, which particularly affects newborns and the immunocompromised, the notes list intravenous amoxicillin or ampicillin, possibly with gentamicin initially, or cotrimoxazole as an alternative.
Good to know the specifics. Any other practical management points from the notes?
Yeah, a couple of things. Fluids are generally not restricted unless there's clear evidence of raised ICP or a specific fluid balance issue like SIADH. Dexamethasone, that steroid, is often recommended for suspected or confirmed bacterial meningitis in adults and older children, not just pneumococcal, because it helps dampen that harmful inflammatory response. And obviously reiterating that the initial empirical antibiotics might be adjusted or narrowed down once the specific organism and its antibiotic sensitivity pattern are known from the lab results.
Okay, so takeaway for management. Immediate emergency action. Hospitalization, empirical IV antibiotics ASAP. Strong supportive care, monitoring closely. Refining treatment once the bug is known. And don't forget the crucial public health aspect: notification, contact tracing, and prevention through vaccines.
That's the comprehensive picture, a multi-pronged, very urgent approach.
So after all that urgent treatment, what can someone expect? What's the likely outcome? Let's talk about the prognosis.
Right, and the notes make it clear that the prognosis, the outcome, is really variable. It depends on a whole host of factors.
Such as?
The specific type of bacteria causing the infection, some are generally more aggressive than others. The patient's age and their underlying health status before they got sick. Critically, how quickly appropriate treatment was started, and whether any significant complications developed during the illness.
So even with modern medicine and fast treatment, it can still be life-threatening. And long-term problems are a real possibility.
Yes, absolutely. Despite advances, bacterial meningitis can still be fatal, and the notes stress that significant long-term neurological problems are unfortunately common among survivors. Prognosis really does vary a lot between individuals, but the notes highlight again, early recognition, getting that treatment started swiftly, and good supportive care are the absolute vital factors for improving the chances of a better outcome.
Now here's where it gets really interesting. The additional prognostic details in the notes are quite stark, aren't they? They really drive home the seriousness.
They are. The notes explicitly state that bacterial meningitis remains a leading infectious cause of death in children here in the UK. They also point out a correlation between how sick someone is when they first present and their outcome. So, a very rapid onset of severe symptoms or being deeply unconscious in a coma upon arrival at hospital, that's associated with a higher risk of mortality.
And there's that slightly counterintuitive point about meningococcal disease prognosis.
Yes, the notes mention that specifically for meningococcal disease, the prognosis might actually be somewhat better if it's accompanied by septicemia bacteria in the bloodstream compared to meningitis alone. It's a noted clinical observation, perhaps related to how quickly it triggers a very strong immune response or forces medical attention.
Interesting.
In contrast, pneumococcal meningitis caused by strep pneumo is noted as generally having a higher mortality rate compared to meningococcal meningitis overall.
The notes also list specific factors that generally point towards a poorer prognosis.
Yes, they list things like delays in getting admitted to hospital and starting treatment, being in a coma, experiencing seizures during the acute illness, having persistent high fever or signs of shock, being very young, especially a neonate, and, as mentioned, having Streptococcus pneumonia identified as the cause.
And just for comparison, the notes briefly touch on the prognosis for viral meningitis.
Right, usually much better. Viral meningitis typically resolves on its own, often within about 10 days or so, although it's worth noting, even viral meningitis can sometimes leave people with longer-lasting effects like persistent fatigue or headaches.
And prevention strategies are mentioned again here in the context of improving prognosis overall.
Yes, the notes link back to the impact of routine vaccination programs in childhood and adolescence. Also, screening pregnant women for Group B Streptococcus and offering antibiotics during labor, if positive, which prevents many cases of neonatal meningitis. And that whole public health response notification, giving antibiotics to close contacts, all these measures, reduce the number of cases happening in the first place, which is the best way to improve the overall population prognosis.
Right. So the takeaway for prognosis: bacterial meningitis is incredibly serious, potentially fatal, especially if there are delays or in specific vulnerable groups or with certain bacteria like strep pneumo. While treatments have improved survival, long-term problems are common even for those who do survive. How sick you are at the start and the specific bug involved really matter.
It's a stark reminder of why vigilance, prevention, and rapid action are just so crucial.
Which leads us directly into the potential long-term impact. Even for those who survive the acute illness, what kinds of problems can arise during or afterwards? Let's look at the complications.
Okay. The notes list both immediate complications, things that can happen right during the acute phase of the illness, and then the longer-term issues or sequelae.
So, immediate complications.
These include really serious things like septic shock, where the infection overwhelms the body, causing dangerously low blood pressure, falling into a coma, significant cerebral edema, that brain swelling we talked about, leading to dangerously raised intracranial pressure.
What about other problems affecting the brain or related systems?
Yes, the notes mention things like subdural effusions, collections of fluid building up between the meninges and the brain surface. SIADH can occur, that syndrome of inappropriate antidiuretic hormone secretion.
The fluid balance problem.
Right, causes the body to retain too much water, which can affect sodium levels and brain function. Seizures are a common complication during the acute illness. Hearing loss is a very well-known and frequent complication. And dysfunction of the cranial nerves, which can affect things like vision, eye movements, facial sensation or movement, or even swallowing.
And the potential long-term consequences sound pretty significant too.
And can be, unfortunately. The notes list potential permanent neurological deficits. This could include intellectual impairments, difficulties with learning or memory, problems with coordination or balance, known as ataxia, visual impairment, or even blindness. And then some rarer but devastating complications like Waterhouse-Friderichsen syndrome.
What's that?
That's a catastrophic failure of the adrenal glands, usually linked to overwhelming meningococcal septicemia, often with widespread bleeding into the skin and organs. Very high mortality. Peripheral gangrene, which is tissue death in the fingers, toes, or limbs, can also occur in severe cases, again, particularly with meningococcal septicemia causing blood clots in small vessels.
Wow. And that statistic about the proportion of survivors with long-term issues is really quite sobering.
It is. The notes state that a significant percentage, somewhere between 30% and 50% of survivors of bacterial meningitis, may be left with some form of permanent neurological problem. And they make the important point that even though medical care has significantly improved survival rates over the years, the rate of these significant long-term complications hasn't always decreased to the same extent.
So the takeaway for complications:
Yeah.
surviving the initial infection is just the first hurdle. There's a wide spectrum of serious potential problems, both immediate and long-lasting, that can affect brain function, hearing, vision, and other body systems. The impact can be profound.
Absolutely. It underscores the incredibly high stakes involved with this disease.
Wow. Okay, that was a really thorough deep dive into bacterial meningitis, pulling out all those key details from the listeners' revision notes. We've covered it from the microscopic bacteria right through to the potential lifelong impact. It is clearly a complex, urgent, and pretty scary condition.
It really is. Understanding the different causes, recognizing those key symptoms, knowing the absolute urgency for diagnosis and treatment, and being aware of the potential outcomes and those significant complications, all of that is just critical knowledge.
So if we pull all these threads together, what's the big picture message here? What does this all mean for someone revising this or just wanting to understand it?
I think it reinforces that while, thankfully, public health measures like vaccination have made a huge difference in reducing how common it is, bacterial meningitis remains a swift, incredibly severe, and potentially devastating disease when it does strike. It absolutely demands that rapid recognition and immediate action. Because even with all our modern medical advances, the risk of significant, permanent, long-term neurological impact remains disturbingly high for those who survive.
Yeah, and that actually raises a really important question for me. Given how fast this disease can hit and that high rate of lasting complications, even when people do get prompt treatment, What more needs to be done? Maybe in terms of public awareness of those early, subtle signs, or faster pathways to diagnosis and treatment, or perhaps even developing new therapies specifically aimed at reducing that inflammatory damage to minimize those long-term neurological problems for survivors. That's definitely something to mull over, isn't it?
It's a crucial question for ongoing research and public health strategy.
Absolutely. Well, if you found this deep dive useful, especially if you're grappling with medical revision or just want reliable, high-yield health info condensed down, remember the source material for today came from resources related to PassThem, srli.com, and freem.srli.com. Definitely worth checking them out for more great revision material.
Thanks for joining us today for this deep dive into bacterial meningitis. It's been quite the exploration.
It certainly has. See you on the next one.